I know some other folks feel strongly about DISE, but I still like to do before almost every case, including MMAs. So I still do a ton of DISE, probably, maybe 30 a month as kind of a prerequisite before we do any other kind of surgery.
I just saw Michael Gunson, by the way, for my own case, and he said that he really wants me to do a DISE before I proceed. So you're definitely
Yeah.
not the only
Yeah.
A-lister in the field who likes DISE. Maybe you could briefly explain what DISE is.
Yeah.
And also, why do some people consider it controversial? Because to me, it's very common sense that it would be a useful metric.
Yeah, so I think what a sleep endoscopy is essentially a sedated airway exam. So, the patient comes into the operating room. Some people can do it in like some kind of surgical suite or even clinic. You give the patient propofol. In the US, it's propofol. Other people use, Versed or midazolam, other types of medications, but you slowly deepen them until they get to a point where they're starting to have sleep apnea, snoring, sleep apnea. And then you look with a camera through the nose at the back of the throat, and you look at the entire airway from the soft palate to the side walls, to the tongue base, to the epiglottis to see what is going on when they're having their sleep apnea. So it gives you an idea of if there are certain structures that are collapsing, is there a bunch of redundant soft tissue that might be blocking if they have big lingual tonsils, or, some patients will have, it's less common, but like a floppy epiglottis that is kind of closing over the airway. So, it takes about 20 minutes total. It's a relatively short exam. The issue or the controversy about it is that it can be highly variable. So it depends a lot on the anesthesiologist, so how much propofol you're giving, because if you over sedate someone, everyone's airway is going to collapse. So like everyone, I don't care if you have zero sleep apnea, it's going to look like, you have an AHI of 100. If you under sedate them, you're not going to collapse things enough. So that's one thing. The other thing is there have been studies that show it reproduces stage 2 sleep. So, people have done a PSG or sleep study under propofol. And so you reproduce at least light sleep, but you can't reproduce REM with propofol. So it's not a perfect, view of the entire night, but I still think it gives a decent kind of overview of the anatomy and physiology.
And when it comes to it not being able to produce REM, does that mean it would be more likely to give you false negatives because in REM, people are more likely to have apneas? At least that's what Dr. Anil Rama explained to me, was that REM is kind of the most problematic sleep stage for a lot of these incidents. So would that be the concern?
I mean, no, it's more of like the sleep apnea is going to be worse during REM. So you can sedate someone enough to like show what their airway would look like when they're having apneic episodes, but like it's not going to show how much worse it gets during, that 10 to 20% of the night they're in REM sleep. So that's certainly a part of it, but you can still get people deep enough to show kind of what's going on in their airway.
Yeah.
But then there's things like you're on your back versus like, do you sleep on your stomach or your side? So, trying to figure out patient's body position and have them try to be in a natural sleep position when you're doing the sleep endoscopy can also sometimes be useful.
Yeah, that makes sense. Although I find that most people move around a lot when they sleep. They'll spend some time on the side, some time on the back. I personally, no matter how bad back sleeping is for me, and it is bad, my body will still go there. And some people think that the back is the most natural sleep posture just because it evenly distributes, force along the back and the spine, whereas side sleeping is inherently kind of unhealthy in its asymmetry of forces. So I think from a common sense perspective, the DISE makes a lot of sense. I think it's definitely useful. And then do you also when you're doing the DISE, do you take their mandible and kind of slide it forward to see if that resolves the pharyngeal airway issue?
I do. Yeah. So I do what's called an oral appliance simulation or mandibular advancement simulation. So, you can gently kind of grab their lower teeth and chin. You don't want to jaw thrust someone because that's going to arouse them and then their airway is going to look awesome because they're not sleeping anymore.
Right.
So you kind of gently pull the jaw forward and you can see, okay, how much does this pull the sidewalls out? How much does this move the tongue out of the way? Does the soft palate open up? And that can be an example, of one, would they tolerate something like an oral appliance device? So if you have an older patient that, is intolerant to CPAP, maybe something like an oral appliance, which again has all of its own inherent, downsides to it. But like, are you going to do an MMA on a 75-year-old that has heart failure? Probably not. So there are other types of interventions that you can do. And then it also, maybe gives some data about what would an MMA kind of look like if you pull the jaw forward, say a centimeter or And again, it's not moving the upper jaw, so you have to take a little bit with a grain of salt. It's, certainly an MMA is going to make a bigger difference on the patient's airway than just a mandibular advancement simulation.
Yeah. How nerdy are you on the brain science of sleep apnea and your understanding of why it is that REM sleep is you have more apneas in that stage of sleep? I asked Dr. Rama this question, and it wasn't too clear. He didn't really have too solid of an answer on that. One thing I've noticed in my own experience is that usually, the way I got into this whole space was that I would go to bed sleeping great, and then I would wake up with these really nasty headaches. But it was a little bit more precise than that. I would actually go to bed feeling great, wake up sometime at 2 or 3, also feeling great, go to bed at 4-ish, wake up again at 6 or 7 feeling awful. And that was also the time when I was having really vivid dreams, so presumably a REM stage of sleep.
Yeah.
So the whole REM stage being more problematic for sleep apnea is very personal to me, but I don't have any understanding of why it is that stage of sleep is so difficult on the airway.
So I'm certainly not, they're experts in airway physiology much better than me, but I think kind of in the most rudimentary kind of understanding of it is that your entire body is essentially paralyzed during REM, other than the eyes and the diaphragm. So your upper airway muscle tone is kind of the most decreased during REM sleep. So if you have a smaller airway to begin with, if you have skeletal deficiencies, those are exacerbated during REM. At least that's kind of my understanding, is that you have the least amount of muscle tone supporting the patency of the airway or the openness of the airway during REM.
And what's the relationship between that being the case and also the fact that we tend to dream more in REM? Is the paralysis a kind of prevention from you acting out your dreams? Is that
Absolutely.
What's going on?
Yeah. So, there are patients that have what's called REM behavior disorder, where their body does not paralyze and they will act out their dreams, and they can get injured, try to climb out a window, go out their front door, all these different things where or hitting your bed partner is the most common thing. So that's kind of the biggest thing, is it allows you to dream without acting out, everything that you're doing.
Yeah, that's very interesting.